And with immunotherapy being approved for MRD negative consolidation, what are the biggest unanswered questions in this field from your perspective? For instance, do we know the optimal duration of immunotherapy, or the sequence, or how to sequence it with transplantation and maintenance? What do you think are some of the biggest areas that need to be focused on?
Well, a big one is how much immunotherapy is needed. So in E1910, we said give 4 cycles. Now, not all the patients got 4 cycles. Some of them couldn't make it to that because of side effects or other issues. Um, there are some studies showing that as few as 2 cycles. Now, this is a study that was done in pediatrics in younger patients, and these were what are called standard risk pediatric patients. So, people are asking, would 2 cycles be enough in adults? Can
Mm,
we extrapolate from the pediatric results? And I think we have to be cautious about that. So I think we don't know what the optimal number of cycles are. I mean, there are some studies where they've given up to 7 cycles of blinatumomab.
mm,
Blinatumomab is expensive, and particularly in resource stretched areas of the world. It's too expensive to give that much blinatumomab. Remember, I said it was also given for 4 weeks. Some people have asked, well, would 2 weeks be enough? Do we need to give the full 4 weeks, or can we get to MRD negativity with, say, or get to MRD negativity or maintain MRD negativity with 2 weeks rather than
mm,
4? So I think the duration of treatment is probably the biggest question. The second one is, how much can we cut back on the chemotherapy now that we have immunotherapy available?
mm. How do you see the role of MRD evolving as both a prognostic and a predictive biomarker as more immunotherapies become available? Do you?
Well, I think it's going to play a continued role. I think we're going to get more patients to MRD negativity. And so we'll want to have the capability to assess for that. And then the MRD testing is also important for monitoring after patients are done with treatment. Because if we can pick up an early relapse before it becomes, full blown and makes a person sick, then we can intervene with other therapies and get that back to MRD negativity, get the leukemia back under control before
Mm,
it creates more havoc.
mhm. Have you seen, because we have these conversations about cancer specifically and rates increasing in different populations. Have you seen any changes in your practice in the age of cancer diagnosis, or anything like that from your personal practice experience? Or is it mostly studies in
Well, I
your?
wouldn't say so much with ALL. Now, there is one subset of ALL that we're seeing more increasingly, and that's in patients with multiple myeloma
Mm,
who go through treatment. They get on maintenance treatment with something called Revlimid.
mm,
And we're seeing that a number of those patients are developing ALL, which is kind of a surprise to us. So that's something new. Um, in the broad area of cancer oncology, we're seeing solid tumors develop in younger people more often, which is not something I personally have dealt with, but I've read about, and I trained in oncology, and that's really how I'm going to say throwing oncologists a bit off balance, to see young patients with, say, metastatic colon cancer, which is a tragic thing to think about. But um, and to get at your
mm.
question, that's one area that I think about.
Yeah. Yeah, that's definitely been an area that has been coming up.